So on behalf of Sai Society of Rural Healthcare and Rehabilitation, I welcome you all for today's webinar. This webinar will be for 1.5 hours, in which 1 hour will be presentation. And at the end of presentation, there will be a question and answer session for 15 minutes. You can write your question in the chat box during the presentation as well as at the end of presentation. After question and answer session, you will be asked to fill the online feedback form, which is mandatory for those who are willing to get certificate. I hope it will be a fruitful session for you. So thank you so much for joining this webinar. Now let me introduce today's speaker, Dr. Susmita Mahapatra. Dr. Mahapatra is a specialist occupational therapist with a vast experience in stroke and neuro rehabilitation. She is currently working as a lecturer in occupational therapy in the Department of Health Sciences, Brunel University, London, and as a consultant therapist in Barts Health NHS Trust. Previously, she was a clinical lead therapist at King's Hospital, London, and a specialist advisor for a Care Quality Commission. She has experience in leading multidisciplinary rehabilitation care pathway also. Now, Dr. Mahapatra has graduated in 2001 in occupational therapy from NIRTAR, National Institute of Rehabilitation Training and Research, from Utkal University in India, followed by a master's degree in neurorehabilitation from Mumbai in 2003. Master's degree in management in health and social care from Oxford Brookes University, UK in 2010. And she has also done PhD in rehabilitation of severe stroke survivors from University of Nottingham, UK in 2018. She is also a fellow in Higher Education Academy in England since 2019. She is passionate about improving healthcare through her innovative research. She has several high-quality publications under her name and currently involved with developing several national guidelines with the National Institute of Clinical Excellence, UK. At last, I would say that she is a good friend of mine. Thank you, Dr. Susmita, for giving your precious time for sharing your knowledge and expertise. Now, once again, thank you to you, and over to you, Dr. Susmita.
Thank you. Thank you for the kind information and kind introduction. I hope you can hear me. Can you hear me, Santosh? Yeah, okay. Right, so thank you very much for the kind introduction. I'm delighted to present here, and thank you SSRHR for giving me the opportunity to share my experience with you all. And I'm hoping that for the next 1 hour, whatever I'm going to be talking is going to be helpful for you actually. So we'll see how we're going to do that. So today I'm going to be discussing the challenges and evidence around shoulder management after stroke, with special emphasis on shoulder subluxation. So I'm just going to share my screen. Hope you can see. Santosh, just let me know if you can see my screen. Can you see my screen? Right. I hope. Santosh, can you see my screen? That's okay. You just send your just raise your hand and I'll know that. That's okay. Okay, so I'm just going to start without wasting any further time. So in the next hour, as I said, I'll be covering some of the important topics. So I will just go through a very quickly understanding the shoulder complex, reasons and types of subluxation, some of the assessment and evaluation tools, and then some of the evidence and guidelines, and then prevention and management, especially focusing on risk assessment and clinical reasoning. I hope this information, this is a large topic actually. There's so much I can talk about it for the whole year probably. But I'm just going to cover in next 1 hour as much as I could do and I hope that whatever information I give today will guide your approach towards managing an hemiplegic shoulder. I just need some charts, so I'll just be back just 1 second. All right, I hope this is working. So I usually start with a quiz, but obviously this is not an interactive session, so I'm not going to go through this one. So I'm just going to quickly go through all these things on my page. So we know that the shoulder is a ball and socket joint, and which has got 3 linkages to the body, through the acromioclavicular joint and glenohumeral joint. It has got 7 joints. Hopefully you all know about it: the glenohumeral joint, suprahumeral joint, acromioclavicular joint, scapulocostal joint, sternoclavicular joint, costosternal joint, and costovertebral joints. So these are all 7 joints. So when we are talking about the shoulder complex, we all need to know about all these joints. There are 4 main muscles that makes it stabilized, which are the sits, also called as the supraspinatus, infraspinatus, teres minor, and subscapularis. The instability of the shoulder is due to the size of the humeral head, which is three times the size of the glenoid fossa, and that makes it really, really unstable. The stability is due to these 4 bigger muscles, and especially which are called as the rotator cuff muscles. It is also stabilized by the glenohumeral ligaments, most prominently the inferior glenohumeral ligament, and also the coracohumeral ligament. There are so many other structures that makes it stabilized as well, but these are the most important one. The bicep tendons also make a big contribution towards making it stabilized. And we also know about the scapulohumeral rhythm, which is about the first 30 degrees of the movement, flexion and abduction, is actually supported by the humeral or initiated by the humeral head, and then the rest of it is covered by is taken over by the scapula. So these are some of the things that I've already told. So the main things we need to know is about 3 bones, 3 independent linkages, 7 joints, 3 types of soft tissue, the ligaments, the labrum, the glenoid labrum, and the bursas, and the 4 major muscles that I told you about, the rotator cuff muscles. These are the main things. Then something more about the shoulder complex. These are the most important structure, again, for the stability. As I said, ligaments are the main source of stability for the shoulder joint. So when we are talking about instability, there is something wrong with the ligament, and sometimes it is deceived by the ligamentous laxity, you can say. So the lax joint is, sometimes you just think that, okay, there is a subluxation, but it might be just the laxity of the ligament. And these are the main ones, as I told you: superior, middle, and the inferior glenohumeral ligaments. Bursa, again, these are the sacs that helps to reduce the friction between the muscle, the tendon, and the bone. Subacromial bursa is the main structure, again, that gives the shock absorption around the shoulder joint. But again, bursitis, any inflammation can actually deceive as something wrong in the shoulder, but it might not be anything wrong with the shoulder, but it could be just a bursitis, the inflammation of the bursa. And the glenoid labrum, as I told you, that is the main thing that gives the stability to the joint. So there are several types of stability of the glenohumeral joint. 2 I have just put it here: the dynamic stabilizers and the static stabilizers. The glenohumeral joint, as I said, because it gives a lot of mobility to the shoulder joint, it is actually a little bit unstable anyways, because this is the mobility superimposed on stability. So the glenohumeral joint actually relies on the integrity of the musculature around it and the capsule, which is supported by the labrum, and they provide the stability to the joint. As I said, there are a few different types of stabilizers or stability that provide stability to the glenohumeral joint. The first thing is the dynamic stabilizers. as that is on the screen, the dynamic stabilizers are due to the dynamic action of the rotator cuff muscles, bicep brachii, and the deltoid. Those are the main ones that, because of their contraction or the dynamic action, the joint is stable. There are some static stabilizers, which is the glenohumeral joint itself, the capsule supported by the labrum, the glenohumeral ligaments, and the negative pressure within the joint capsule, the bony congruity of the joint. They are static stabilizers. They give the stability to the joint. There are two other stabilizers as well. One is the scapular stability provided by the scapular rotators, which are the trapezius, serratus anterior, rhomboids, and levator scapulae. So they, by the contraction of the scapular rotators, they give the scapular stability. The last type of stability is the postural stability of the upper quadrant, which are given by the levator scapulae and the upper trapezius muscles. So you can see that the muscular make around the shoulder joint actually provides a lot of stability. So anything that goes wrong with the muscles actually makes the joint really, really unstable. And that's exactly, you can see what happens in a hemiplegic shoulder. The musculature loses its capacity or loses its dynamic activity, which is because of the spasticity or flaccidity as a result of stroke that makes the joint really, really unstable. So there are three types of shoulder subluxation. Literally, shoulder subluxation means the partial separation of the humeral head from the glenoid cavity. Basically, the head comes out of the glenoid cavity. Either, usually it is partially. If it is comes out completely, then it is usually called as dislocation. Also, dislocation is more associated with the trauma, and if it is due to stroke or due to the muscular instability, then it is usually called as a subluxation rather than a dislocation. So there are three different types of subluxation, as you see in the shoulder: the inferior glenohumeral subluxation, anterior glenohumeral subluxation, and superior glenohumeral subluxation. The most common one after stroke is anterior inferior subluxation. Either it's an anterior subluxation or inferior subluxation. Usually, if it is due to flaccidity, then you see an inferior glenohumeral subluxation because of the weight of the arm that is pulling down. And if it is due to the spasticity in the pectoral muscles, then you usually see an anterior subluxation. Superior glenohumeral subluxation is usually not very common. Sometimes it can happen due to the tone. So why I'm talking about shoulder subluxation, although the webinar is about hemiplegic shoulder. Common post-stroke complication, one of the most common post-stroke complication is actually humeral subluxation. In 80%, sometimes it goes up to, the figure goes up to 85%, is due to the 85% of the complications around the shoulder after stroke is actually due to subluxation. So that's why I'm just going to focus a little bit more on shoulder subluxation today. So as I said, it's the most common complication after stroke. It developed during the flaccid stage of the post-stroke. That means if you are going through the flaccid stage of stroke, like as you know, sometimes you do not have the flaccid stage and you directly go into a spastic stage. But if you're going through the flaccid stage, then it's most likely that you will experience subluxation. Brunstrom arm motor stage is a significant predictor. That means if the person is at Brunstrom stage 1, which is the flaccid stage, it's highly likely that they are going to have subluxation. So it's a really significant predictor of a risk of a subluxation. And research says that without treatment, subluxation can worsen. So if you don't do anything, then it will worsen. And if it is worsened, then over time, it can eventually become uncorrectable, and it can eventually lead to a lot of pain, loss of function, loss of a lot of things, and lead to a lot of other secondary complications. So it's better to do something rather than nothing. So management should be an important part of upper limb rehab. When you're talking about stroke rehab as a whole, then management of shoulder subluxation should be a major part of it. And one last important point here is it is not always associated with pain, and it may have different causes. Although we always think that shoulder subluxation means pain, it may or may not be associated with that one. And pain can come from other sources as well. Sometimes you need to just find out. There are a few pathomechanics I would like to discuss here. As we know, the shoulder has got 6 degrees of freedom, and those muscles that I told about, which gives the stability, they also give the instability to the joint, because they pull the shoulder joint in different direction, as I've put it in the picture. There are a lot of different forces acting there. So some of the mechanism is that some research says that in the flaccid stage, scapula is descended from a horizontal position to, and the rotator cuff is enabled to support the scapula, or you can say that the arm on the scapula, so it's unable to support it, and that leads to the major cause of subluxation. In the spastic stage, what happens is the hypotonic pectoralis major and minor, they actually pull it in different direction, and that can lead to scapular dislocation. They pull the scapula in different direction again, and that can lead to dislocation of the scapula. And however, the latest research says that the scapular position is not an important factor in the subluxation. It is actually the muscular inactivity that leads to shoulder subluxation rather than the scapular glide. Although, having said that, scapular glide also contributes in a major part of the subluxation is due to the scapular glide, but it is not the sole reason for subluxation. So these are some of the pathomechanics. Traction of the rotator cuff, as I said, on the superior joint of the scapula. So either because of spasticity or flaccidity, if the traction or the force in the rotator cuff muscles are altered, then definitely that can contribute to shoulder subluxation. Obviously, as I said, because of the weight of the arm, there is a prolonged downward pull on the arm. So if the arm is not supported, gravity itself can be a big cause, and it is the biggest cause of subluxation, because if it is unmanaged, if you leave it unmanaged, then it leads to subluxation. Severe motor deficit, as we know, hypotonia, because the muscle has lost its dynamic properties, and the damage of the muscular function, that leads to subluxation to a greater extent. And the same thing is due to the weakness as well, because of the weakness, lack of tone, and lack of any dynamic action in the muscle, that can lead to subluxation. Some of the other functional reasons, or some of the other secondary reasons, you can say, what leads to subluxation is improper positioning in bed. So if the person is in a flaccid stage and you are not handling the person in a correct way while they're in the bed, or while they're lying to sitting in a chair, and that can lead to subluxation. That might not be due to stroke, but it is because of the improper handling of the and which you can call it as a secondary cause for subluxation. What is the impact? Now we know what is the impact. The first and foremost, as therapists, we can say that the most first and foremost impact of shoulder subluxation is actually the functional impact. There is a lack of function, and there's a lack of participation of the whole arm in anything. But there are other things that can be associated with shoulder subluxation as well. One major thing is the increased incidence of sympathetic reflex dystrophy, or otherwise called as the complex regional pain syndrome, CRPS. So if you have got a shoulder subluxation and it is unmanaged, then there is a higher chance that it can lead to RST or CRPS. Not always associated with that one, but it can lead to that, and there is a higher incidence or higher likelihood of having that. If you leave it unmanaged, if you do not have a plan to manage the shoulder subluxation, it can lead to rotator cuff injury. It can be the other way as well. It starts with a rotator cuff injury and then it worsens. Or if you leave it unmanaged, that can lead to rotator cuff injury because of the overstretching of the ligaments and the muscles. Shoulder pain and impingement, inheritedly, like if you have got an unmanaged shoulder subluxation, it can lead to shoulder pain and impingement. Obviously, as I said, there will be a lot of functional difficulties because of the reduced shoulder range of movement, because of the lack of support, to counteract gravity, and the complex soft tissue of the shoulder gets injured because of that. Sometimes because of the extended hospital stay, and then the patients are discharged, like I'm talking about the UK context, obviously, because the patients are getting discharged from the hospital very quickly, and the education is lacking within the patient and their carers, then it can have a lot of effect on increased pain, and then the lack of quality of life of the person as well. So I'm going to talk about some of the assessment and evaluation. I'm just going to keep an eye on the time as well. So very quickly, I'm not going to go through all the assessment and evaluation, but I'll touch very briefly on some of the things that you should do for a hemiplegic shoulder. So the history taking is the first stage. So as you can see, there are 6 stages of assessment. So history taking, then observation, palpation, measure, and special tests. So when you're taking the history, obviously you look for demographics and pre-morbid function, past medical history. Especially in the past medical history, you are looking for any arthritis, diabetes, and all those kind of things, because they can have an impact. You're looking at any other reasons, any other medical history that can have an impact on the musculature around the scapula or the shoulder, which could be any neuromuscular diseases, if they have got a childhood neuromuscular diseases, or if there is any muscle atrophy due to other reasons, that can have an impact on top of stroke as well. So you need to find out those things in your past medical history. So that's very important while you are doing this one. And then obviously you need to check for medications, and that will give you a clue about the any kind of again diabetic, or if there is any pain medication they're already taking, and all those kind of things. And obviously you'll check for the presenting condition, how bad is the stroke, how severe is the stroke, what are the other risk factors. So history taking is quite important. Then you go for your observation, and here your surface anatomy comes into place. So you just check for normal anatomical make of the shoulder, both the anatomical like the bony alignment and the musculature around it. So you look for surface anatomical structure, any kind of asymmetry, atrophy, edema, skin contour, if there is any breakdown of skin, any change in color, any change in temperature, sensation, all those kind of things, any kind of active range of movement and passive range of movement, you need to check for that one. And you know how to do those kind of things. You can use a goniometer to check those things, or you can just observe the functional range of movement as well. You need to check for other associated reactions, because there might be, because of spasticity, there might be other reactions, like you know that when you're yawning, your hand is going into flexion. That means there is a really high flex synergy. Then those kind of things can give rise to more of a, or that's a high risk of subluxation as well, especially if there is anterior subluxation. So you need to find out that if there are other associated reactions there. And obviously you need to look for any sign of discomfort, especially when you are doing any active range of movement or passive range of movement. You need to check for signs of discomfort. That means that is going to give you a clue about the pain and where the pain is coming from. When you're going to palpate the shoulder, obviously you need to look for the shoulder landmark, like the GT, the glenohumeral head, and the acromioclavicular joint. So you need to check the rim of those things and just see if there is on palpation, if there is any pain, and that is confirmatory that it is definitely coming from the joint and not from the muscle. So obviously you need to look for tenderness in the musculature around it as well, which might give you a clue around whether there is any injury to the muscle, like especially the rotator cuff. The tenderness of the muscle when on palpation also give you a clue about if there is any pain due to spasticity as well. So you need to have a good feel of all the muscles around the scapula. The next one is obviously measurement, and you're going to measure the range and the power. So range of the shoulder. So as I said, there are 6 degrees of freedom in shoulder. So all the shoulder movement, like not only the glenohumeral joint where you have the flexion, extension, abduction, adduction, internal and external rotation, you also need to check the range for the scapular glide, the scapular glide on the thoracic cavity as well. So you need to check the range for those. So elevation, depression, protraction, and retraction as well, you need to check. And then the power, obviously, you need to check the power in the muscle, tone and power both. in the musculature around the shoulder, especially those dynamic stabilizers, as I said, the rotator cuff, all the rotator cuff muscles, the scapular muscles as well. And the most important one, as I said, the rotator cuff. So the external rotators and the internal rotators, you need to check the strength, because if they do not have the strength, that is giving you the clue that obviously there's something wrong with the rotator cuff, or it is actually because of the subluxation, they are getting weaker. The last one on my slide here is your special rest, and I'm going to show that in the next slide as well. But these are the three main ones that you check for shoulder subluxation: laxity test, apprehension test, and relocation test. Those are the three that you most commonly do. And I do not think I've got time to go through all those tests with you. And when we have a face-to-face seminar kind of things, then it's important to go through those tests, but I'm just not going to go through those. But as long as you are aware what are the tests you need to do, then it is good enough for today's session. So the other assessment that you need to look for is the radiography. There's standard radiography, a standard X-ray that you can give. It can give you an idea about whether there is subluxation. So if there is a glenohumeral inferior subluxation, then definitely X-ray of the shoulder will give you that idea. Sometimes it is not. It doesn't give you, and because of the edema, a lot of edema around it, if there is bursitis there, if there is inflammatory markers inside the joint, then it may or may not give you an accurate feature for that one. And sometimes we go for MRI, but usually if it is an inferior glenohumeral subluxation and it's a clear one, then you can definitely see it on a normal X-ray. Sometimes we do ultrasound method to detect any minor asymmetry. So if you're detecting some kind of superior one, so because of the spasticity, if there is a subluxation there and you cannot find out just by palpation, then you can go for ultrasound methods to detect minor asymmetries. Most importantly, as therapists, we go for clinical evaluation. As I said, when you go for palpation, that's the most common way of clinical evaluation. So you go for suprahumeral space, which is basically you put your hand and just find out between the acromion process and and the humeral head, just see how much space is there. You can either put your finger in there to find out how much gap is there, or you can use calipers for an accurate measurement. You can also do anthropometric measurement. That means basically it is the arm length discrepancy. So that means you just start from the top of the acromion process and then just go for the lateral epicondyle of the humerus, and that's the length of the arm. If there is difference between the other side, so when you check with the other side of the arm, if the arm length are not similar, then that definitely is telling you that there might be some kind of subluxation there. So obviously this method is more appropriate for inferior subluxation, so inferior glenohumeral subluxation. So before going into the assessment, I'm just trying to tell you some key findings and history of physical examination. Obviously, there are a lot of things that can go wrong with the shoulder, and there are a lot of different kind of shoulder examination that are present there. So some of the findings, like if you find there is scapular winging, trauma, or recent viral illness, then it is probably indicating towards serratus anterior and trapezius dysfunction, which could be flaccidity in serratus anterior and trapezius. That could be due to stroke or could be due to trauma as well. If there is an ability to passively or actively rotate effective arm externally, this is a very clear indication that there is some kind of dislocation there or subluxation there. So any kind of rotation, external or internal rotation, if there is any kind of pain or there is restriction, that is clear cut telling you that there is some kind of dislocation is going on there. Pain radiating below the elbow or decreased cervical range of motion, sometimes it is indicative of cervical disc disease. Although you can think that, okay, it looks like something going on in the shoulder and you probably are thinking of shoulder subluxation, but usually it's a radiating pain. Doesn't usually happens with the shoulder subluxation. So it is clearly indicating about towards cervical disc disease rather than shoulder subluxation. The most common one that is indicating towards the shoulder subluxation is your shoulder pain, and anterior glenohumeral joint pain and impingement. So these three signs definitely says that there is glenohumeral joint instability, which could be due to subluxation. Okay, so pain or on palpation or some clunking sound when you are doing any overhead motion. So when you are lifting your arm overhead, that means you are doing elevation and higher range of movement in flexion or abduction. There is clinking or pain sign, then there is more likely it is a labral disorder rather than a dislocation. Nighttime shoulder pain is usually indicative of impingement rather than subluxation, and generalized ligamentous laxity could be multi-direction instability. That means the shoulder is not only unstable in one side, it can go it is unstable in all different directions. So that is generalized instability rather than it's a subluxation. These are some of the special tests. As I said, I do not have time to go through these, but these are some of the special tests that is done to identify or differentiate between shoulder subluxation and other shoulder anomalies. The most common ones, as I said, palpation of the acromial clavicular joint. That is basically to tell about any pain there. Apprehension test, most commonly done to find out whether there is shoulder subluxation. Laxity test, because that gives that if the joint is not stable, and it is when you're putting pressure, as you see in the picture, when you put pressure anterior posteriorly, then there is some instability that you can induce that instability, and then you can induce some pain, and that gives you clear indication of shoulder subluxation. Cross arm horizontal abduction test sometimes gives you an indication. So when you do that, internally rotate and go to horizontal abduction, that actually brings the shoulder out of the joint, and that is again clear indication of shoulder subluxation. Impingement test may or may not give you indication of shoulder subluxation, but that definitely gives you the impingement of the rotator cuff. That means either the rotator cuffs are lax, or there is a gap that is not supported by the rotator cuff. So that is mostly indicative of something wrong with the rotator cuff, which may be due to shoulder subluxation. So that is very commonly done as well. And the last one that is done is the Hawkins test as well. So you basically abduct the arm and then go into external rotation, or from internal rotation to from external rotation to internal rotation, and that gives you a lot of pain and instability, and that is again is indicative of shoulder subluxation. Okay, so those are the special tests. So the basic general assessment, what you do in a shoulder subluxation is that you look for palpable difference in the muscle bulk. If there is any wasting or atrophy, that is telling you something. Or tonal changes even, that is telling you something about the shoulder. So hemiplegic shoulder, these are very common signs, which is may or may not be indicative of shoulder subluxation, but it is saying that the shoulder needs attention. So you definitely need to have a check the muscle bulk on either side and just have a comparison. Obviously look for the position of the scapula and the thorax. Just see whether there is the scapula has descended downwards or it has glided to one side, because that very commonly happens once you put the stroke survivor into a sitting position, then it definitely happens. But again, it does not indicate that there is shoulder subluxation, but you need to check those things. So these are general examination that you must do in a hemiplegic shoulder. The other thing is the trunk alignment. Obviously, if the trunk is not aligned, that means if there is weakness on one side of the trunk and if it is tilted to one side, that gives you the false sign that the scapula has glided downwards. That means there might be subluxation, but it might be just the trunk misalignment. So you definitely need to check for that and correct it before you go and check for the shoulder subluxation. Obviously, you go for palpation, check for the scapulohumeral rhythm. If that is distorted, then definitely it is indicative that something wrong is going on in the glenohumeral joint and might be indicative of glenohumeral subluxation. Obviously, you check for range of movement, both passive and active, and check for any pain, edema, and swelling around the shoulder joint. I'm going to talk about a little bit of evidence. So what is the evidence? Now we know all these things, we understand the mechanism of what is going on there, but what does the evidence say? Obviously, I'm coming from a UK perspective, and I'm sure the NICE guidelines are actually accepted internationally. So I'm just going to quote something from the NICE guidelines. And you see that the guidelines mostly are talking about shoulder pain, but not talking about shoulder subluxation. So all these guidelines, like there is insufficient evidence to recommend that electrical stimulation for shoulder subluxation can actually help the pain. You can see that. So all these guidelines that are talking about shoulder pain, but some of these things we can actually apply to shoulder subluxation. So the first one, I'll give you an example. The first one says that there is insufficient evidence to recommend electrical stimulation for shoulder subluxation. That means you should not be routinely using electrical stimulation if there is a shoulder subluxation, because every patient is different, every shoulder is different. If you think the person has got musculature that has got a little bit of activity there, by functional electrical stimulation, I can actually increase the muscle activity, then yes, it is important for doing that. But if you just think that, okay, you found a glenohumeral cavity, there is an increased glenohumeral space there, routinely you just do not go for functional electrical stimulation because it will not have an impact, but it is patient specific. Okay, so I'm not going to go through this one. You can have the slides and you can check those guidelines. Similarly, the Sign 18 guidelines, these are the Scottish national guidelines. They also talk about mostly shoulder pain, as you can see, the post-stroke shoulder pain. And you can see that what is not recommended are the overhead pulleys and functional electrical stimulation. Those two things are definitely contraindicated if there is shoulder pain. You know, you should not be doing again routinely, but these are controversial because you can use some of those things for shoulder subluxation. Like you can see, there are insufficient evidence for prolonged shoulder positioning, enhanced physical therapy, and all those kind of things. There are insufficient evidence. That means you can use them judiciously with the patient who are appropriate for them. Okay, it's not, you should not discard them, but you should not be using them routinely. For shoulder subluxation, again, it says that you can consider electrical stimulation, but there is insufficient evidence of slings and supportive devices. Insufficient evidence does not mean that you should completely discard it. It should not be routinely used, but you can choose your patient where it is appropriate. Similarly, there is some more evidence about functional electrical stimulation, as you can see in the graph below, both in the chronic and acute stage. If you give functional electrical stimulation, there is actually some improvement. There is actually some improvement both in the acute stage and chronic stage. So that means the conclusion is, you should not be completely discarding any MS for shoulder subluxation. It is actually useful, but again, as I said, it should be patient specific. Some more evidence I have put here, when added to some other research says that there is no significant benefits of functional electrical stimulation on shoulder pain. As a NICE guideline says, that it may or may not have any impact on shoulder pain, but if you're trying to reduce the cavity and you have got some movement in the muscles, there's some activities in the muscle, it might increase the muscle activity. The most important thing is you give functional electrical stimulation, but you need to use that within an activity. Otherwise, the effect is not going to be long lasting. So if you do that, there might be significant improvement in reducing the glenohumeral cavity there. So that there could be an impact on the functional electrical stimulation. Now, these guidelines I have put there, again, these are NICE guidelines. They are talking about electrical stimulation for upper limb, and you can see that it is highly recommended. There is significant improvement in upper limb motor outcomes. Now, when they are talking about upper limb motor outcome, they're talking about the shoulder, hand, wrist, elbow, everything. So you should not confuse between the guidelines about shoulder subluxation and upper limb motor outcomes. Yes, there is significant evidence around there that, you know, if you have functional electrical stimulation in the wrist and the fingers, it has got a very good result in improving the functional movement of the hand, but not in the shoulder. So there's limited evidence for the shoulder. So do not confuse about that. The next one is shoulder devices or the slings, whether the use of the sling is indicated or not. Again, the guideline says, the Cochrane guideline says that there is insufficient evidence to conclude whether slings or wheelchair attachments could prevent subluxation. Again, you need to interpret these results very judiciously, because it says that there is inconclusive evidence or insufficient evidence to use slings to reduce the subluxation or prevent subluxation. Definitely, it is not going to prevent subluxation, but it is going to prevent secondary deterioration. That means it could maintain there. It is a reminder, so it can be helpful. So this is what the key messages I'm going to give you here is there is insufficient evidence. That does not mean that you completely discard it. You need to just use it when it is appropriate, and you need to make sure why you're using it. So there are some positive things about using the sling, which is it supports the weight of the arm, especially when you're immobilizing. When the person is sitting, you don't need to use a sling. But if the patient is walking, maybe you need to use a sling, because it's a reminder that you need to elevate or you need to shrug your shoulder a little bit to support. But routine use of sling, definitely not helpful. And it obviously protects the arm from further injury and prevents any overstretching. So if it is momentarily, so if you're walking short distance, you definitely need to use a sling. But if you use it for a prolonged time, it is not going to be helpful. And if you think that by providing a sling, I'm going to reduce the pain or improve the pain in the shoulder, again, it is not going to help with that one. So you need to interpret these results in a nicer way, actually, because they are a little bit confusing. Another management is shoulder strapping. So again, there is no significant benefit of shoulder strapping for shoulder subluxation, for correcting shoulder subluxation. So it might not correct shoulder subluxation, it might not reduce pain, but there are some evidence that it can be used as a reminder, actually, because if the strapping is there, it is providing a lot of proprioceptive feedback for the person to know that, okay, I need to elevate the arm, and then just keep it in an elevated position or shrugged position, so that it will prevent further deterioration. So few things here about strapping. Again, to be effective, strapping must be begun very soon, as quickly as possible. In a chronic stage, the evidence is not so clear. So you need to start in an acute stage. And the next thing is re-strapping is necessary at least every 3 days. So you need to change the strap every 3 days. Otherwise, it is going to cause skin damage, infection, and all those kind of things. So if you're using strapping, you must know, your clinical reasoning must be clear why you're using it. So as I said, the positive points of using strapping are, it ensures proximal support of the soft tissue at all times. So it makes sure that the proximal support is maintained in the shoulder. It reduces the subluxation while allowing free movement. Like if you put a sling, it restricts a lot of movement, but if you use a strapping, it actually allows the movement, which is a positive thing. So if you have got some activity in the shoulder, you should go for strapping. It helps. I'm not going to go through much about medical management, because the only medical management for hemiplegic shoulder is pain management. So you go for analgesic or anti-inflammatory drugs, sometimes steroid injections, and sometimes you need to reduce spasticity, because spasticity can increase shoulder subluxation or shoulder pain, or it can restrict any kind of shoulder movement. So obviously you need to look for anti-spasticity drug like baclofen or Botox, if obviously spasticity is the main cause for functional impairment. So I'm just going to give you some idea about different stages of hemiplegic shoulder and what can you do. So when it is flaccid, that means the shoulder is at a Brunstrom stage 1. That means there is no or very little active muscle movement around the shoulder or the scapula. Then you need to provide preventative strategies. So you need to start with the preventative strategy, because the shoulder is not going to help itself. You need to do something. As a healthcare professional, you need to do something to the shoulder to make sure that it is managed well. So you consider all those preventative strategies that I talked about. Introduce some kind of movement with electrical stimulation, because you want those muscles to be active a little bit. If there is nothing there, you need to try to activate those muscles. So you try to do that. Obviously, by doing things like strapping, things like other kind of proprioceptive feedback, you're trying to reconnect your mind to the muscles. So there's a little bit of cognitive therapy going on, because the brain is tending to forget that arm. So you're trying to focus that the brain should not forget. So you're trying to connect the mind to the muscle. Try to maintain pain-free passive ranging. And obviously active assisted if it is possible. But as I said, if there is no little or active shoulder movement, then you probably need to go for more of a preventative approach. Positioning is very important, and encourage any kind of movement, whatever they can do. At this stage, as I said, neuromuscular facilitation is a good idea to do that. So Try to activate the muscle and try to strengthen whatever is left in the shoulder musculature. I'm not going to stay on the slide because this is talking about where to place the electrode. And whatever protocol you are going to use, the recommended protocol for FES is 6 hours daily, 5 days a week for 6 weeks at least. And that will make a difference. If you just do a little bit of FES here and there, that is not going to help. So try to do, if you're doing it, try to do it at least 6 hours daily. And obviously you can't do that. So in the UK, what we try to do, we start with a program, and then just we train the patient and the family members so they can take it over. And the FES machine is as a we try to give them a pre-programmed machine so that they can do it easily, and the hours could be increased, the doses can be increased. When there are some activities around the shoulder, obviously try to do as much active assistive as possible. Try to minimize passive movement because passive is actually not doing anything. So if there is activity, encourage the activity. Start with gentle exercises. At this stage, you can try with weight bearing exercises because that is going to give you those stimulation to the muscle that is required. And it will prevent any kind of synergy if that is present. If it will decrease spasticity, because spasticity management is a big issue for shoulder management. So try those kind of things if there is some activities around them. Do not use sling. Definitely do not use sling. If there is activity, discard anything else. If there is activity, then you need to start up with anything that the patient can do for themselves. Slings, functional electrical stimulation, all those kind of things and preventative strategies are more for when there is no activity at all. Okay. Right. And obviously education, family education is very important. Some kind of precautions I think I've already covered. Extreme care must be taken during passive range of movement. As I told you, that you need to make sure that elevation is done before you do anything, any kind of, sorry, so you correct the subluxation first before you do elevation, then, internal rotation with flexion and all those kind of things. So make sure that those kind of preventative strategies you're using, especially when you are doing passive ranging. And obviously, use caution when you're using hemiplegic slings. Now, I'm not sure in India we use a pathway, but in UK there is a lot of discussion about pathways. If we make a pathway, that means we know what to do first, what goes next, and and we try to put them into categories. It's not always a good thing, but it's good and bad, you can say. Sometimes pathway works. So I'm just going to give you an example. This is called as a Mathers pathway. It's a tool, it's a management tool for hemiplegic shoulder. We try to use in my clinic or in my ward as well. We try to use this in an inpatient unit. We try to use this pathway. So what it does, it has got 4 different questions here and 4 different outcome measures. As you say, is the shoulder, the first point is about passive ranging. So we need to find out how much passive ranging is there, and you give a score from that one. So if the score is yes, then you give 3. If the score is less than 50 degrees, then the answer is no, and you give a score of 0. Same thing, you talk about shoulder pain, and there is something called as a Ritchie articular index, and it has a 4-point scale, and according to, so 0 is where 0 is no tenderness, +1 is patient has got pain when you try to move, then there's a complaint of pain. When you try to move, then there is a little bit of pain, and then the patient actually is trying to winch, then it's a score of 2, and those kind of things. So according to the score, again, you give, if the score is yes, the Ritchie articular index is more than 1, then you go for a score of 2. And if it is less than 1, then you go for a score of no, that means score of 0. So like this, you give all the scoring, and based on that, you come up with a whatever you call it, is like a table, and that gives you a guidance about the intervention. So if the risk is 0, then you go for usual care. That means you go for exercises, mobilization, strengthening, whatever you want to do. If the total score is low, that means between 1 and 3, then you go for education and self-management. So you go for education, that means you just ask the patient and the carers and the nurses, you teach them how to take care of the patient's hemiplegic shoulder, like all the preventative strategies, use of slings, whatever you try to do. So you teach and you give them self-management so the patient can manage. You don't need to do actively anything. If the score is really, really high, that means the score is between 4 and 10, then you need to do immediate assessment. What we try to do, we assess the shoulder every week or every fortnight and make sure that the score is going down. If it is not going down, then you need to do daily monitoring, daily therapy requests, daily preventative strategy, education. You need to do all this positioning throughout the day, and all the FES, like all the management strategies that I was talking about. So this is a pathway. So you can actually categorize the patient into 3 different categories, and then that guides you through the intervention. So I think I'm coming to the end of my presentation. So a few things to remember. The shoulder socket is actually a very vulnerable joint and is very susceptible to problems. So obviously after stroke, it makes it much more vulnerable. So some are preventable and some are treatable. So we need to make sure that we manage between prevention and management, or prevention or treatment. Sometimes shoulder subluxation goes away, and sometimes like naturally it fits back, and sometimes treatment is required. So you need to monitor it very carefully and very closely and do as directed or as required. So your clinical reasoning is most important. So there is not routine that if there is a shoulder subluxation, this is what I'm going to do. Don't do that. You need to have your clinical reasoning, and this is why monitoring is required. Like as I said, sometimes it cures naturally, sometimes it doesn't. It is important to keep it safe and engage functional tasks. So try to engage it in an active functional task. So try to use that shoulder as much as possible, because that helps to maintain the health around the hemiplegic shoulder. Obviously, repetitive practice, there's a lot of evidence that repetitive practice is the best treatment. So go through that. And that is not only for the shoulder, that is for every single, every extremity that is affected by shoulder, every extremity that is affected by stroke. So shoulder is no different. So just go through that and then just try to do as much task as possible. The problem is when there is no movement at all, then that's where you need to jump in and just try to talk about it and do a lot. There is a right way and the wrong way to sling use. As I said, you need to use it. If you're trying to think, if you're thinking of using a sling, try to use it carefully. Use your clinical reasoning, do your risk assessment. And as I said, the Mathis tool is a good one to give you a risk score to your shoulder. And then you can treat it, and then you can decide whether to use slings or not. And obviously, remember, slings are only for short term. Do not use it for long term, because that leads to learned disuse of the shoulder, and that's not a good thing. In summary, no technique could be effective in reducing subluxation and facilitate limb recovery. The only way to do that is through active movement. So try to encourage active movement as much as possible, wherever possible. The problem is when there is no movement at all, and that's where you need to jump in and just do something. Okay, but there is no one medicine, or there is no one therapy for shoulder subluxation or for hemiplegic shoulder. Every shoulder is different. Use electrical stimulation whenever you think that it is appropriate. In the acute stage, in the flaccid stage, it is more important because you need to just encourage the muscle. But in the chronic stage also, it has been found to be helpful. But the most important thing about functional electrical stimulation is that you need to use the muscle. Once you wake up the muscle, you need to make sure that you're using it. Gentle range of movement exercise is helpful for preventing secondary dislocation. Try to make sure that range of movement exercise is active assisted. Try to avoid passive if possible. If you're doing passive, you need to be extremely careful that you are using all those preventative strategies. If you're using taping or strapping of subluxation, there is conflicting evidence. So be very, very careful and make sure why you're using it, and do not use it for long term. And that's all I have to say. Thank you for your patient listening to my talk, and hope that was helpful. I'm happy to answer any questions now.
Thank you, Dr. Mahapatra, for this wonderful presentation. Now the session is open for questions. I got few questions from the audience. One of the questions is shoulder subluxation curable? And is there any outcome measures for that?
Okay, I'm just going to stop sharing this one and so that I can talk. So whether shoulder subluxation is curable? Well, that's a big term actually. When we talk in therapy, I don't think so we talk about curing anything, because something that has gone wrong usually stays with us. So the word I would use here is, rather than cure, I would say whether shoulder subluxation is manageable. I would say yes, it is manageable. I would not say it is curable, but as I said, naturally, sometimes if there is some activity in the shoulder, it might come back naturally in some patient, but sometimes it requires treatment or management. So I would say it is manageable, not curable, but it is definitely manageable.
And the second part of the question is there any outcome measures for that?
Yes, one of the outcome measures I talked about is MATHAS, which I usually I try to use more commonly, because it's specifically for shoulder, hemiplegic shoulder, and then you can use it to monitor the risk of the shoulder and stuff like that. So MATHAS is a good outcome measure. If you just want to know how much subluxation has happened and if it is increasing or not, there are two outcome measures I would like to mention here. One is the Oxford Instability Shoulder Score, OISS. It's called OISS. So that is one of the outcome measure. The other one is also called as Western Ontario Shoulder Instability Index, OZ, like WOSI. If anybody is interested, I can tell more about it. But those are the two outcome measures, I would say, or three outcome measures. The MATHAS and these two are three outcome measures that you can use for measuring shoulder, hemiplegic shoulder.
So, there is one more question, that what is the relation between subluxation and pain? I think the person, the audience, is willing to know that is pain because of subluxation?
Right.
Or there are other reasons of that pain?
Yeah, so there are, I think this is a chicken and egg situation kind of thing, you can say, that which comes first. There is definitely a correlation between shoulder and shoulder pain and subluxation. So, but you cannot say that pain is due to subluxation or subluxation is due to pain, but they are correlated to each other. There is higher incidence of pain if there is subluxation, and vice versa as well. If there is shoulder subluxation, it can lead to pain, but you cannot say they are causative to each other. That means one doesn't cause the other one, but there are a lot of other reasons as well. So hemiplegic shoulder pain is a very common thing, and this is what I was saying in the NICE guideline. As you can see, it is more talking about the shoulder pain rather than shoulder subluxation, because we try to treat shoulder pain because that's more common, and there are a lot of other reasons why you can have shoulder pain. The pain could be due to subluxation, that could be due to spasticity itself. Even though there are no subluxation, there is only shoulder spasticity around the shoulder musculature that can give rise to pain. There could be just because of the pull, because of the muscles not supporting the arm. It could give rise to RSD, as I said, reflex sympathetic dystrophy, or central regional pain syndrome as well. So there are a lot of other reasons why you can have pain in the shoulder. So as I said, they're correlated, but I would not say there is causative relation between those two.
There is another question from Dr. Sujata Missal. Have you ever used taping for pain and subluxation?
As I said, there is no evidence for taping helping with pain. But so the taping or kinesiotaping is usually helpful for the proprioceptive feedback, as a reminder of the brain that this hand needs to be, the arm needs to be supported. It's a reminder to the musculature that they need to be actively supporting the arm over this over the shoulder, over the scapula. So there is no evidence that it can cure the pain or it can relieve the pain. And it depends, again, where is the pain coming from? And this is what I'm trying to say, that when you are looking for a hemiplegic shoulder, we need to find out where is the pain coming from. If the pain is coming from spasticity, obviously taping is not going to be helpful. If the pain is coming from subluxation, maybe it might be helpful because it is supporting the arm a little bit. So it might lead to. So you need to identify where the pain is coming from. So if your question is whether kinesiotaping is helpful for pain reduction in a hemiplegic shoulder, my answer will be no. But we need to find out where the pain is coming from. And there is there is a breadth of evidence, actually. There's no evidence that routinely, if you do taping, then it will be painful. But whether I have used taping for pain, my answer is again no. I have used taping for shoulder subluxation, definitely. But not for pain.
There is one more question. What are the clinical reasoning for prescribing shoulder sling?
Clinical reasoning for prescribing shoulder sling. As I said, if the person has got cognitive difficulties or inattention or neglect, no matter how much ever you say that, okay, you need to hold on to your shoulders, reduce your subluxation while you are sitting up in a chair or sitting to standing, they won't remember it or they will not. So it's a cognitive reminder. Actually, the sling works as a cognitive reminder when you are transferring. So if there is a higher level, if there's a high risk shoulder, that means there is a larger subluxation there and the person has got inattention to that side, or when there is a lot of trunk instability, that means the person is focusing on something else and forgetting about the shoulder. The best method is to actually put a sling there momentarily. Obviously put a sling there, you make the person transfer from either from lying to sitting, sitting to standing, whatever you are trying to do. And while you are doing that, you're not trying to focus on the shoulder, because you're focusing on the trunk, you're focusing on the leg, you're focusing on transfer, and that's the point you use the sling. If you're doing a little bit of mobility practice, again, only 10 meters of walking while the person is learning how to manage the shoulder, sling is a good option. For the short term, during therapy, it's a good option. I would go for other options like positioning on a chair or positioning on a bed. That would be better. Like while the person is sitting on a table, it's better to put the arm on the table rather than putting in a sling. But momentarily, if the person is starting to stand up and go to a wheelchair, that's the point. Gravity is acting too much, and that's the point you can use a sling. As long as you're using it for short term, it's fine, but not for long term. If you put a sling and forget about it, then it is a problem because it will lead to learned disuse of that shoulder.
There is one more question. Somebody is asking that what are the exercises to be done in flaccid stage?
In the flaccid stage, it depends what you want to do. Actually, as I said, my approach would be to start with a little bit of functional electrical stimulation. If there is nothing going on there, it's completely flaccid, there's no muscle activity, then I'll do a bit of functional electrical stimulation, mostly targeting to the rotator cuff muscles. And as I said, there are two dynamic stabilizers, the rotator cuff muscles and the scapular rotators. So all those muscles, I would try to do a little bit of FES to awake those muscles. And once those muscles are awakened, I would mostly go for setting exercises, or whatever you can call it as shrugging exercises. So basically that would help with the rotator cuffs and the scapular ones. So any kind of activity like shoulder shrugging, which is like elevation, depression, protraction, retraction, even if it is small range movement, those are the first ones to start with in the flaccid stage before going to large range movement. Like if you're doing even flexion and internal rotation, it should be done within the first 30 degrees, not more than that, because it will make the shoulder more unstable.
One more question here. Mm-hmm. How severe shoulder pain can be treated?
Sorry, say that again.
How severe shoulder pain can be treated in starting? I mean, the audience, somebody is trying to ask that how severe pain can be treated in the stage of, in acute stage, in fact.
In acute stage, okay. So if there is severe pain, again, your approach is, as a therapist, your approach is first we need to find out where the pain is coming from. If it is a spasticity pain, due to the spastic muscles, the pain is coming from there, or is it coming from the joint because of the muscle tear there, or is it from the subluxation, or is it from the rotator cuff injury, or is it a bursitis? We need to find out where the pain is coming from. There is nothing called, okay, how do we treat the pain? Like try to find, if it is a CRPS, your approach will be completely different. If it is a central regional pain syndrome, your thing is going to be completely different as opposed to if it is a spastic pain. Now, let's say there is severe pain because of spasticity. Then you need to go for the spasticity management thing. First thing, I would go for an injection like a baclofen or a Botox injection to release those spasticity, and that might reduce the pain itself. I don't need to do anything at all after that. If it is coming from central regional pain syndrome or RSD or something like that, maybe I need to go for higher level pain relief like gabapentin or something like that to reduce the pain first, manage the pain, and then you go for activities. the same thing that we do, like the shrugging exercises, passive ranging, or whatever, functional electrical stimulation. But what you are trying to do is, in severe pain, you're trying to minimize the pain or increase the pain threshold so that you can do all these activities, because the only way you can reduce those things by actively using those musculature. The pain prevents those actively using those musculature. So we need to manage the pain, and the most important way of managing the pain is medical management. And if it is as I said, if it is spasticity, you go for spasticity management. If it is pain due to some other reasons, then you need to go for a pain management medication first. And then once you start to actively use them, then hopefully the pain will reduce, even if it is coming from spasticity. Hope that makes sense.
One more question is, what type of slings are available in the market, which can be used in case of hemiplegia?
Right. There are a lot of different kind of slings. The image that I showed you, the hemi arm sling, that is most appropriate. You'll see that there are long arm slings where your hand is held like this. Definitely that is contraindicated, because that is keeping your hand in internal rotation and inflection, elbow flexion. That is definitely going to increase your learned non-use and increase your spasticity. If you have got synergy, flexor synergy in the arm, it is going to increase that. So that is definitely not going to be useful. The hemi arm sling is the most common one that is available in the market and is useful actually, because it is only coming from the shoulder, from here top there. So there's nothing to do with the elbow. So you leave the arm alone, you're just supporting the shoulder, and that's all is needed. So do not go for the full arm slings where the arm is hold like this one, because that actually doesn't help. So the most common, if you just called as a hemi arm sling, that is the most common one available in the market, and is the most appropriate one as well. But obviously be very careful while you're using those slings. Do not use it for long term. People get used to that one and they just say, oh, it's really comfortable. Actually, I just want to keep the sling on for the whole day. Don't do that, because then they won't use those arm muscles.
Yeah, I think there is no more questions. So
Okay.
thank you so much for this wonderful presentation.